I'm starting the recording back. We were at like 50 minutes, so I didn't want to go over. All right. Any more questions on that? No? All right. So this is where I'm going to get on my soapbox, and I might get a little teary-eyed. This is my mom. Some of you know she passed away from a medical error. So that's my son and my daughter and my nephew. This is why what you do is so important. You are taking care of somebody's family member, somebody's loved one, somebody's kid. They mean somebody to someone. In general, we're human beings, right? We should all mean something to somebody. So when we ask you in clinical why you're giving a drug, what is the dosage, how much should you be giving, we are not just trying to bust your balls, okay? We want you to understand that your patient, there's a reason you're giving the drug. There's a reason your patient is getting that drug. There's correct dosages. There's lots of, what you do is important, okay? And you should care enough to understand why you're doing what you're doing. Because if you mess up, people get hurt. And I know that's a lot of pressure to put on somebody, but you guys are the last steps. Accidents happen all the time. And if you don't care enough to stop and say, I don't understand why I'm giving this drug. I don't understand the dosage. I don't understand this. Because a nurse told me that she didn't care. The doctor wrote an order and she gave it. So that was my mom. And 3 days later, that was my mom. From acute respiratory distress syndrome. She had a little cold. I probably undiagnosed pneumonia, that, walking pneumonia like a lot of people have. Got sick in the morning, like threw up, which happens often with pneumonia. They throw up and aspirate. So she got sent to the hospital. She was intubated, so she was in respiratory distress. She takes anticoags because she had a history of a carotid endarterectomy. She got admitted on a Saturday. The weekend team wrote for an anticoag. The night team wrote for an anticoag. And the week, when the team came back on Monday, they wrote. By Tuesday, she was hemorrhaging in her lungs. And the nurse basically told me, when I asked, because I just said, why? I don't understand. I don't understand why she's on all of these meds. And she said, that's what the doctor wrote, so get over it, basically, is what she told me. When you guys look at us and say, well, I don't know what they're getting that for, that's not acceptable, because there may be a reason it's missing or that it's wrong. All right? So with that, and I don't mean to bring you all down, I just want you guys to understand how important it is. And that when we're getting on you as instructors, it's just honestly because we want you to be the best you can be. Okay? So with stages of ARDS, again, here's normal. Normal alveoli, blood coming through, CO2 being blown off, getting O2. Then they start developing some edema. And then the alveoli fill. This can be because of direct and indirect lung injuries. The most common is sepsis. So when we talk about SIRS, it's a big cause of why patients develop ARDS, but it also can be because of an aspiration, a pneumonia. We don't really know why there's damage to the alveoli, but we think it's because of some inflammatory process. So the lungs get damaged and inflammatory mediators kind of come and like the immune system. The immune system kind of kicks into gear. It sends all these inflammatory mediators and then your body reacts, right? They start getting some fluid developed. How exactly it happens, they're not 100% sure, but they believe it's something to do with that immune system kind of kicking into gear. And there's 3 phases. We'll take our break after we get through this, guys. So the first phase is that injury phase. This is within a week after the insult. It could happen right away. And basically those capillaries become more permeable. So you have those capillaries that are going around, right? And and they're surrounding the alveoli. They're going around surrounding that alveoli, and they become more permeable. So they're leaking fluid. They're leaking fluid into that interstitial space and into the capillaries, or into the alveoli. So again, that blood can't be oxygenated, right? Because we have that shunt occurring. And then we have that balloon. So we have those alveoli that are becoming overstretched and surfactants not kicking in. So you have atelectasis developing. So surfactant is what gives the alveoli that ability to kind of open. So every time those alveoli open, that's when, so when we take a breath in, right, alveoli are opening up. That's when oxygen's being pushed into the capillaries and CO2's coming. When we exhale, those alveoli are closing. Do the alveoli close all the way? No. They stay a little bit open. But the surfactant is what opens and closes them. It opens and closes them. When you've got ARDS, basically that surfactant goes away, and so you're kind of getting, oh, I can't get all the way open, right? Because it's overstretched. So if I can't get all the way open, am I going to have the same gas exchange as when my alveoli were all the way open? No. Fibrosis develops. Fibrotic tissue, right? It's kind of like scar tissue. It's thick. Does thick scar tissue work the same way as normal tissue? No. There's that severe VQ mismatch that we talked about. So it's refractory hypoxemia. It doesn't matter how much O2 you throw at them because they can't have that exchange because their alveoli aren't able to open up all the way because they have atelectasis, decreased surfactant, and they're filled with fluid. And oxygen and CO2 can't participate in the exchange. So lungs less compliant. They have a stiff lung is what we call it. So we need a lot of pressure. So they have to work really hard. They have to take this nice deep breath in order to get the same kind of pressure in their alveoli. So what are we going to see in this beginning stage? They're working really hard to breathe, right? And again, if they're working really hard to breathe, they're not getting as much oxygen, they're going to get really restless, right? Oh, I'm restless, I'm anxious, I'm going to be, dyspnea, I don't feel good. And their PO2 is going to drop below 60. They're going to have a high respiratory rate. Which one? Work of breathing. High work of breathing. Respiratory rate. They're working hard. The respiratory rate's high. They're restless. Their PaO2 is less than 60. So we're starting to see signs and symptoms of hypoxia. Less than 60. Yep, less than 60. So the alveoli fill with fluid. There's atelectasis. So the lungs aren't working right. So You have the increased work of breathing, the increased respiratory rate. They're struggling. That's the beginning. The next stage is this reparative stage. And this is a week or two after the first injury or insult. And this is where we talk about that inflammatory cells. So those neutrophils, monocytes, lymphocytes, fibroblasts, that whole inflammatory process is kind of initiated. All these mediators get kind of sent to the area because they're like, oh, the body's not working, we're here to fix it. And that actually makes things kind of worse, because that's when the capillaries become more permeable and they start filling with more fluid. So the lung becomes dense, more fibrotic, which is a problem, because can we repair scar tissue? No, that's why when Miss Lewis talked about MIs, and why it was such an issue, because they develop scar tissue, and scar tissue can't, have conduction through it normally. Same thing with the lungs. When we talk about fibrosis, when those lungs become fibrotic, it can become irreversible. And once it's irreversible, you're never going to have that same gas exchange. If the lungs aren't working as well, and we have a lot of resistance, that's when we get pulmonary hypertension, right? The lungs have to work really hard. That hypoxemia worsens. And like I said, if it persists, that fibrosis is going to be widespread and it's going to be irreversible. If you can stop ARDS at this stage, then the lesions will resolve. But if they keep going, if you can't stop it at this stage, that fibrosis becomes permanent. So again, that's why it's so important that we recognize early signs and symptoms, and why we're providing symptomatic treatment, we're treating the cause. So if, the number one complication is that they develop, sepsis, right? So if my patient is septic, that's why we have those, SIRS alerts that goes off in the hospital, because they're saying, oh crap, this patient's septic. They could develop ARDS, they could develop MODS. So we're going to go ahead and start treating with antibiotics and everything else. Why treating the symptoms? Because if we can stop it, they can get better. But once this phase continues, it's irreversible. So the last stage is the fibrotic. And this is, about 3 weeks after the injury. The lung is completely remodeled by fibrous tissue. So, again, we don't have that lung compliance. Fibrotic tissue is kind of scar tissue. It doesn't work the same way. So normal alveoli are going to open and close. Scar tissue doesn't get that open, right? That balloon can't inflate. Think about like a brand new bag of balloons that you blow up and they're nice and like squishy and really stretchy. And think about those balloons that you found that have been in your garage for like 7 years. And you try to blow them up and they're all like hard and stiff, right? You can't blow them up the same. So there's not as much area for gas exchange. Remember, we're talking about this. Just kidding, we're not. It's not going to write. So this, oh, that looks bad. But that's our capillary, right? Going through, the blood going through. And that's our alveoli. That gas exchange is happening there. It's happening there. It's happening there. It's happening there. It's happening across the whole alveoli. So if you now have an alveoli that it's, happening all across, and now you've got this littler alveoli, does it have as much space? No. If it's not opening up as much, do you have as much space to have that exchange? No. Pulmonary hypertension, that's when we develop that right-sided failure. So some people survive the acute phase, the edema resolves, they get complete recovery. Survival chances are poor for those who enter the fibrotic stage. 80% of your patients that develop ARDS will die. So only about 20% live. And those 20% who have entered the fibrotic stage, out of those 20%, those who are in the fibrotic stage, they will require mechanical ventilation for the rest of their lives typically.
You don't want to survive ARDS.
No, if you survive it, like if you catch it early, if you catch it early and you recover completely, then you're fine.
It's the late phase.
But it's the late phasers that survive
Exactly, that's what
that they don't do well. They're going to have long-term complications because just like an MI, that they're always going to have at risk for dysrhythmias, they're just not going to have that lung compliance. So they're always going to have issues. So again, we want to find these things early, right? Because we want to stop this phase. So it's all the things that we kind of talked about. They're not that bad in the beginning. They're a little restless, increased respiratory rate. They might actually have clear breath sounds at this point. Maybe a little scattered crackles. And their ABG is not horrible. Their pH, their CO2 might be a little low. Their bicarb is typically normal. They don't look too bad. And their chest x-ray is normal. Chest x-rays can be a little deceiving because they lag in time. So you can get a chest x-ray of me like in early stages and it's going to be normal. You can also get someone who's been treated for pneumonia and get an x-ray of them 7 days after treatment and you're going to look at it going, oh my God, you have a complete whiteout. But they're actually getting better. So chest x-rays can be a little lag on both ends. So they don't look that bad, right? So that's why it's important for us to recognize the whole picture. What's going on with my picture? Are they septic? Are they at risk for ARDS? Are they showing signs of respiratory distress? Late signs. This is where the lung compliance decreases. So the lung compliance is their surfactant, right? So now you have this balloon that's all old and not able to stretch, and it's filled with fluid. So those PFTs, that's what that is, PFT, go down, right? Because you're throwing oxygen at them, but no matter how much oxygen you throw at them, they're still not satting good. This is when they require intubation. This is when you're going to hear crackles and everything on exam. This is where they become cyanotic. And that hallmark that we've talked about is that they have hypoxemia despite increasing the FiO2. And that PF ratio is less than 200. And this is what I mean by a whiteout. This is actually not a bad whiteout, but do you see all this like fluffiness? It looks like a cloud. That's all fluid. It should be black like this in between the ribs. So if it's not black like this in between the ribs, if you've got like fluffiness, that's fluid. You see it like, and also your heart in a normal chest x-ray, these are very distinct borders. When you have any kind of fluid, you see how you can't really see the borders? All right. So what are complications? We'll get a little bit more into these when we talk about vents. So ventilator-assisted pneumonia. I'm sorry, not assisted. Associated pneumonia. So, nursing care, why is that important to you? If you're taking care of a patient that's in respiratory failure or ARDS, they're on a vent and you get your vital signs and they've got a fever and they've been okay. Are you going to think, uh-oh, I need to catch this early? Is that something you're going to hold off and wait to tell the doc? No. So what are you going to do? What can you go do? If you think there's infection, how do we find out if there's an infection? Cultures, right? So we're going to get cultures. We're going to call the doc and say, patient's got a temp, I sent cultures off. Do you want to start any broad spectrum antibiotics at this point? Until we figure out what's going on. The barotrauma, that's when we're talking about on the vents, that's when we blow air into the alveoli. And sometimes, because think of that thick, stiff balloon. If we try to really blow into that balloon or try to like open it up, what could we do? Tear it, right? That's the same with trauma. I can't ever say that right. Thank you. Stress ulcers, again, this is why we start feeds early. We don't want them to develop any gastric ulcers, any stress ulcers. What are other things we do besides starting feeds early? That's why everybody in the hospital is on a PPI, right? Renal failure. They don't have good cardiac output. I'm going to talk about why they may not have cardiac output when we talk about positive pressure. And again, what do we want them to do? We want their PaO2 to be normal. If we improve their gas exchange, what happens? Why do we want good gas exchange? We want that. Why? What happens when it's 1-to-1? What happens to that blood that's circulating? There's perfusion, right? Tissue perfusion. Our whole goal is tissue perfusion. Because when our lungs aren't pumping out, our lungs aren't ventilating, getting oxygen to the blood, and the blood is not getting pumped out to the body, so we're not getting good tissue perfusion, we're having death, right? Cell death. That's when everything starts failing. We want the SaO2 greater than 90. We want a paid airway. We want clear lung sounds. So our goal is to correct the hypoxemia. And that is with the lowest concentration of O2 that results in a PaO2 of 60. So we're going to start off slow. We're going to, maybe start with a nasal cannula. Maybe increase it to 2 liters, 3 liters. If they start satting 90% on 3 liters, I'm going to keep it there. I'm not going to start off at 10 liters and be like, oh, they're satting 90%, I'm good. I want to start off with the lowest concentration that results in a PaO2 that's greater than 60. We may need to ventilate. And this is the positive pressure. So PEEP is positive end expiratory pressure. Normal PEEP is 5 centimeters. So that's what I was talking about when we said the alveoli open and close. Your alveoli open and then they close, but do they close all the way? No. PEEP is what keeps it open just a little bit, okay? It allows for gas exchange to happen as long as possible. We want the most time possible to get as much O2 and get rid of as much CO2 as possible.
Does that say at 5 on?
PEEP is at 5 centimeters is normal. So what we do when we have somebody with ARDS, and again, we're going to get into this a little bit when we talk about the vents. When we increase the PEEP, so we are saying that normal PEEP is 5. So we open and we close, and that PEEP, I only need 5 centimeters of pressure to keep that alveoli open a little bit. When you have someone with ARDS who has those stiff alveoli, stiff lung, they need a little more pressure, right? Because it's really hard. They're wanting to close down. So then you have PEEPs that are increasing to 10 centimeters, 15 centimeters. So we're trying to hyperinflate. We're trying to keep that alveoli open. The longer we keep the alveoli open, the longer we have what happening? Gas exchange, right? And that's really important, especially for someone who's already having a respiratory issue. We have to be careful, though, because think about it. Here's my alveoli. here's my pulmonary artery, right? The more you increase that alveoli, it can put pressure on that capillary, correct? And my pen is not working because it's dumb. So, okay, so this is the capillary, and it's got blood going through. And this is your alveoli, right? And that PEEP is keeping it just enough open to have as much gas exchange as possible from every end, right? So when you've got a PEEP that's too high, the PEEP will increase the alveoli. So if you get a PEEP that's at like 15, it's going to start pressing in to this capillary. Does that make sense? Okay. So now you've got this alveoli and it's pushing on that capillary bed. If normal is this for your capillary bed, and now you've squished it because the alveoli is keeping it, squishing it down, you've got less blood flow going back to the heart. If you have less blood flow going back to the heart, what happens to your cardiac output? It goes down. So it is a fine little game that we like to play because we need to keep the PEEP open. We need PEEP to keep the alveoli open to have that gas exchange, but we have to be careful we don't put too much because we don't want to decrease cardiac output. So we decrease blood return to the left heart, which decreases blood pressure and cardiac output. So we have to be careful about hyperinflating the alveoli. And we can do things like positioning. They don't always just lay on their back. A lot of times we'll put them prone. We'll put them in a special bed. The beds are really cool. They like flip those patients like all over. So again, our job is to maintain cardiac output and tissue perfusion, right? Maintain fluid balance, I's and O's, daily weights. And how are we going to know that we did good? Because things are back to normal, right? That's why we want to know baseline for your patients. That they don't have abnormal breath sounds. That they have a good cough. That their respiratory rate is normal. That they're using accessory muscles appropriately. They're not having retractions or sucking in. That they don't have any anxiety or restlessness, because those are signs that they're not getting enough oxygen to the brain. That their PO2 is within normal limit. Again, with that PO2 is greater than 60 at the lowest O2 concentration possible. Nutrition, that their albumin and protein are normal. They're not having any muscle breakdown. They're not having any stress ulcers because we fed them. We've provided PPIs. And they don't have any edema. All right. Do you guys have any questions about any of that? I know it was a lot of information. We good? You guys want like 20 minutes? Okay.